Hello, everyone. Welcome to the RISE Population Health Management OHT Virtual Collaborative. Today's collaborative discussion is about applying an equity lens to your populations. We will give everyone a few minutes to sign in before we start. As we wait for people to sign on, please introduce yourself and your organization or OHT in the chat box. You can do this by selecting the chat box in the right-hand portion of your screen and selecting everyone from the drop-down. For those of you who don't know me, my name is Leslie McGeough, and I will be your host for today. I work for Trillium Health Partners, and I'm a focal point with RISE supporting population health management. My colleague, Steve Lott, is also here. Hi, Steve, and he can help you with technical issues. Just message the host, and he can try to help you resolve them. Today's session will build on our June webinar, Applying an Equity Lens to Your Populations. Everyone is in a very different stage of applying an equity lens. Today, we will hear two OHTs and where they are in their journey and how they're thinking about this work. Specifically, we'll hear from Suman at South Lake OHT, and we'll also hear from Salim and Neil from the Brampton Etobicoke OHT. Welcome to Suman, Salim, and Neil. Thank you for joining us today. Don't forget, as you join today, to introduce yourself in the chat box on the right-hand portion of your screen there, and select everyone from the drop-down so we can all see who's there. Welcome, Carol from Mississauga OHT. Nice to see you. Welcome, Victoria from Algoma. Thank you for joining us again. Hi, Catherine from Huron Perth. Lori, one of our coaches, and Karen Armstrong from Guelph Wellington OHT. Hi, Kelly from Provincial Geriatric Leadership Ontario, and Megan from Hills of Headwater. So many people coming in. Great to see everyone here today. We're also very lucky to have with us today some of our guests from the June webinar, Cynthia Damba from Ontario Health, who spoke to us about using data to understand inequities in care, and also Duar Patil from Health Commons Solutions Lab, who spoke to us about mapping community resources as one approach to designing equitable care. Thank you both for joining us again, and we look forward to learning more from you and answering some of our questions today. Welcome, Bianca from Ontario Caregiver Organization, and Amber from Western OHT. Thank you for joining. And Aju, welcome from Brampton Etobicoke OHT. Was this day 4, day 5 now? Welcome. Thank you for joining us. As you join today, don't forget to put your name in the chat box and introduce yourself. We like to say that this is a bit of a community too. It's about exchanging ideas and connecting you with other OHTs. So you can also add your Twitter handle or email to the chat box, and I'll summarize those at the end of today and share them back with you. Hi, Renee from Western York OHT. Nice, thank you for joining us. Arena. Hi, Ingrid from KW4. Thanks for joining us. And Jackie and Rule. Lots here from Brampton and Etobicoke. Great to see everyone. And Nadia from Burlington. Please also continue to send us your feedback. We use your feedback to develop our sessions, including the topics. So you can do that through contacting me. Thanks, Steve, for putting my email in the inbox. But you can also do it by contacting your coach. And if you don't have a coach, you can contact me for one as well. Thanks, Steve, for doing that. All right, well, we're getting close, I think, to the number of those who registered today. So what we'd like to do is we'd like to start today's session by acknowledging the land on which we work. As we work in Mississauga, we are using the Indigenous Traditional Land Acknowledgement Statement, which was developed by the Indigenous peoples in our region. As we meet here today, we are in solidarity, we are in solidarity with Indigenous peoples of Turtle Island, and would like to begin by acknowledging that the land on which we gather is part of the treaty lands and territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit, Métis, and other global Indigenous peoples who now call this area their home. We are grateful for the opportunity to be working on this land. Land acknowledgements offer a moment to reflect on our responsibilities as guests on Indigenous territory And in that spirit, we'd also like to pay our respects to and recognize the growing number of children identified in unmarked graves across Canada, those children yet to be discovered, and all the families who have been affected by residential and day schools in our country. We'd also like to express our solidarity with the families and communities affected by the acts of hate against the Muslim community, as well as those experiencing the continuing impacts of racism across many communities in Ontario. We are committed to working together to take action against racism, and particularly how it influences health and well-being across Ontario. We welcome feedback on how we can continue to do this better, and also how we can better translate this commitment to action in our support to OHTs. I'm now going to pass it over to Mike Hindmarsh, our head coach, who will provide us with an overview of today's session.
Well, good morning, everyone. I'm glad to see so many of you here. The purpose of today's collaborative session is it's a follow-up to our webinar sessions, where it's your time to discuss and ask questions of not only our experts, of which we've got a number on the phone today, but also to talk amongst each other about the work that you're doing and sharing the work that you're doing around applying an equity lens to this transformation journey. We're going to have two presentations today, one from South Lake Community and their equity work, as well as Brampton Etobicoke Ontario Health Team. We also have Cynthia Dambia and Zawar Patel to be able, our experts, to answer questions about diversity and equity issues. We will have about an hour for discussion after the presentation. So feel free to type your questions into the chat box if you want during the presentations or afterwards, but I would love it if you would come off mute and ask your questions, either of the experts or of each other. As I say, this is your time to share amongst each other. We've heard loud and clear from you that you want more time to be doing that, so that's why we've dedicated close to an hour of the time in this particular session. So let's move on to the next slide. If this isn't tattooed into your memory, it will be by the end of this transformation journey. So it's our 4 steps in population health management. Many of you are, depending on which cohort you're in either working on your priority populations and how to segment them or how to stratify them by risk. Many of you are working on co-designing care models with your community partners. And so a lot of today's work around applying an equity lens to that co-design work is what we'll be talking about. Excuse me. Let's go to the next slide. So I'm going to recap the presentations. Some water here. Or coffee, as it may be. I'm going to recap the presentations that Cynthia Dambia did for us last time, as well as Sophia Akura and Zawar Patel from Health Commons Solutions Lab. I've already apologized to them for the violence that I'll probably do to their great presentations. They've forgiven me already. So let's take a look at what Cynthia showed us. And I think the key takeaways, some of the key takeaways from her presentation was that we just can't assume that that populations look a certain way and that they're impacted a certain way. We have to really look at the data and get an understanding of what's going on. So in that graph that you see there, what I was actually quite stunned by was how various subpopulations, various ethnic and racial groups were impacted by COVID, and well beyond the proportions that they represent in the overall population profile. So I think it's important to recognize that these many of these groups that are marginalized and racialized were impacted more heavily by COVID-19. And when it comes to designing our healthcare system, our current system is doing the same thing. It is not providing them best access, not providing them the care that they need, and it's a system that was not designed for them. So that's part of the transformation work that you need to be thinking about as you move forward. Data has to come from multiple sources. Cynthia pointed out that there are primary sources that we can use, but we also need to look at secondary sources. And if there isn't data, you need to think about how you would collect it. And she made a great suggestion around using the COVID vaccination process as a way to collect data that might be missing, whether it's race data, ethnic background, religious data, whatever you need in order to design the care models for those marginalized and racialized populations. Even though we're well on our way and maybe halfway through vaccination, my guess is we'll be having annual vaccinations around COVID. So there's lots of opportunity to collect those data. So something to really think about. And the reason, as I mentioned earlier, that we're measuring health equity is because not only does it inform clinical care, various racial groups have different profiles when it comes to certain chronic conditions. Different ethnic groups have different cultural attitudes towards healthcare. We have to make sure we build that into our care so that the healthcare is safe for everyone and easily accessible. It also allows us to do more appropriate quality improvement, care model design, and ultimately evaluation of whether we're doing a good job or not. So Cynthia, I hope I did some justice to that. We'll move on to what Sophia Akura and Zawar Patel presented from Health Commons Solution Lab. They talked to us about asset mapping. And I think this is a critical piece of work for all of the OHTs, figuring out what are the assets you have within your community partners that can help you build a larger network of not only referral sources, but care across the community. So not just necessarily clinical care, but also care that helps address the social factors, the social determinants of health, and just in general, supporting communities to work better together. So as they had said in their presentation, it helps you develop greater insights into your priority population needs. It helps improve awareness of the local assets that are around you, as well as improving service planning and making sure that you can deliver equitable care in your planning design. It was interesting that they both pointed out that you don't want to assume what's going on in your community just because of generalizing from other communities or historical beliefs, whatever. And they used a great example of the assumption that there's not enough youth wellness programs in a particular area, when in actual fact, once you start doing your asset mapping, you find out that not only do the healthcare providers know an awful lot of support programs for youth, but when you actually look at the services that are available, there are all sorts of them. So you don't want to head down a care model design or transformation process that is based on assumptions of what you have in your community. You actually want to map out what's going on in your community and make sure that you know exactly what is available and what isn't available. There's some great resources from them on how to get started. I'd urge you also that if you haven't started this journey or wondering how to get started, that you talk to Zawar. As you can see, he's on the call and you can follow up with him afterwards. And they have a number of great resources and tools for doing asset mapping, as well as helping you figure out how to actually do it. Okay, let's go to the next slide. So what I want to do is introduce our first presenter, and we're going to hear from Suman Badwani, who is the Community Integration Lead at South Lake, Ontario Health Team. So Suman, I will pass it over to you.
Thank you, Mike. Good afternoon, everyone. It's a pleasure to be here representing my colleagues at South Lake Community Ontario Health Team, but also many of the partners that form South Lake Community OHT that have had a lot of contribution to the work that I'll be presenting today. So it's very nice to meet you, and we'll get started. So the first thing that I'll do is actually provide an overview of the South Lake Community OHT. So geographically, we're actually located in the northwestern side of York Region. These include core geographies of Aurora, Bradford, West Gwillimbury, East Gwillimbury, Georgina, and Newmarket. And as you can see, we have a wide variety of anchor partners who are part of our OHT. This includes strong representation from primary care, family health teams, as well as nurse practitioner-led clinics, alongside service providers of Bayshore, Chats, Loft, St. Eliz, South Lake Hospital, as well as a strong partnership with York Region and the CMHA. I think similar to many of you, our OHT selected two priority populations of older adults with complex needs and multiple comorbidities, and adults with mental health and addiction issues. And for these population groups, we really wanted to focus on 5 areas. The first was improving transitions from hospital to post-acute care. The second was focusing on reducing admissions and ED visits by enhancing coordination within the various aspects that make up community care. The third was ensuring that primary care, community services, and paramedic services focus on rising risk patient cohort. The fourth was a reduction in process and the paperwork that for primary care physicians. And the third was resource shifts from acute to community and primary care. So as you can see, a very tall order, a lot of work to be done. And in order to narrow down our scope, we decided to focus in on transitions from hospital to the community as our first step. So within that, we are fortunate enough to have a transitions working group that's actively working on this and is responsible for a lot of the work that you'll see today, represented by a lot of the partners that I previously mentioned, as well as representation from primary care, as well as a patient and family caregiver member. So a lot of diverse perspectives informing our work. Leslie, could I ask you for the next slide, please? Thank you. So when we look at transitions, there are many different transitions that can occur in our region. And we really wanted to understand how do we go from a broader scope to a more narrower scope with respect to where we might be able to focus on our sites, our transition sites. And so we looked to the data, and the data actually told us a very compelling story. And that's when we looked at 30-day revisits to the emergency department and 30-day readmissions following discharge, we found that patients and clients who were discharged to group and supportive housing had the highest revisit rates to the ED within 30 days. And this was a trend that was consistent over 3 fiscal years, meaning that COVID may have had some impact, but really this was a trend that was occurring even prior to COVID. Similarly, when we looked at the 30-day readmissions data, we saw that patients who were admitted from supportive housing and supportive shelters had the highest percentage of cases readmitted to the hospital within 30 days. And similarly to the ED visits, this trend was also consistent over the last 3 fiscal years. So what this really told us is that there are many transition sites, but the individuals residing in group and supportive housing and the shelter system are actually the ones who are having frequent transitions to the hospital, and really allowed us to narrow down our scope of work to those particular types of sites. We then revisited the data to see if we could really narrow down and find the specific sites where a lot of those transitions and ED visits and readmissions were occurring. But unfortunately, the coding in the data is quite generic, and we weren't really able to pinpoint to a lot of different, a lot of the specific sites where we could examine those high ED visits and readmission rates. So if I go to the next slide, thank you. So we turned the data over to the transitions working group and collectively leaned on their experience, to help us narrow down both the scope of the population as well as the transition pathway that we would be focusing on. So traditionally, we looked at, traditionally there is a emphasis on transitions from hospital to home or community, but we also really wanted to consider how transitions work from community to hospital as well, because we think that that's really setting the foundation for a successful and sustainable transition in the future. For our target population, based on the data that we had collected and based on the experiences of our service providers who are working with individuals at those sites, we narrowed down our target population to adults with complex needs who historically have not had sustainable discharges and were residing in supportive housing and the shelter system. And so then it came time to to select our sites for our tests of change. Our approach was going to be that we would design a test of change where we could implement a quick plan, do, study, act cycle to see if we design a solution to help improve transitions, where that might be able to take place. And based again on the experience of the representatives of our transitions working group, we decided on 3 criteria to select our organizations, which I think is very important to share for others who are also looking at doing some of this work. The first was a willingness for the organization to partner and change some of their practices. So this is a very feasible point, but I think a very important one, because we were really looking for someone who could partner with us and be interested in changing some of their practices as we designed our test of change. We also wanted to ensure that there was a possibility to spread and scale the initiatives to other similar types of locations. So we didn't want to select a site that was so unique in context that we wouldn't be able to apply our learnings and our test of change to other sites because it was so unique and dissimilar to other contexts. And the third was that we would have existing partnership with one of our anchor partners and the ability to tap into existing or leveraging existing activities that were already underway. And so the 2 organizations that we selected was Blue Door, specifically Porter Place Men's Shelter, which, as you can see, has many partners already part of its organization, as well as Keswick Gardens. Again, a list of partners are listed on this slide. So if we go to the next slide, I'll give an overview of Keswick Gardens. So Keswick Gardens is a subsidized housing site that is operated by York Region. It has approximately 120 apartments, affordable housing. CHATS is a community service provider that has set up an 24/7 assisted living program within the site. PSW support is available 24/7 within the site, and it can include things such as meal prep, medication checks, not medication checks, reminders for medications, light cleaning, etc. CHATS operates on a hub and spoke model within the site. So the hub is the actual building where it includes 40 clients. And then the spoke is 10 to 15, the perimeter 10 to 15 minutes around the site in the community where CHATS has 5 clients. So a total of 45 clients that are receiving PSW services within Keswick Gardens. Specifically, the client population, the average age is 80 to 85. They're largely English speaking and of a white Anglo-Saxon background. They're generally lower income, and the units are occupied more by singles and couples, and family members are usually not as involved in care, not because they want to be, because circumstances perhaps prevent them from being involved. Some of the clients have mental health and addictions challenges, and the clients are really meant to be living independently and independently managing their health. But what's been noted is that they have increasing frailty, they're aging, and so many of the clients are not able to self-manage their care and coordinate care across the different complex sites that they receive care from. Some of the common reasons listed for ER visits and readmissions to the hospital were falls, pain, and shortness of breath. And from one client interview, which we were able to do interviews with this, which I should have mentioned earlier. We were able to do interviews at Keswick Gardens, at Blue Door, and South Lake Hospital with organizational leaders, frontline providers, and supervisors, and one client at Keswick. And the client interview was very enlightening. And the reason for their visit to the hospital was actually medication management, because they did not have access to the specialists that could arrange for their medications to be changed. So some really interesting perspectives were gathered through that client interview. So if we go to the next slide. So Blue Door Porter Place. Blue Door is the largest emergency housing provider in York Region. Porter Place specifically is a men's shelter, and it has 30 beds. Most of the clients are experiencing homelessness. They're typically 27 years and older. But more recently, the organizational leaders at Blue Door have mentioned that they are noticing that the clients are actually much older. So they're 50 years older, 50 years and plus. Diverse ethnic profiles of clients who are residing there. The length of stay for clients at Porter Place is 30 days, but can range up to 6 months. And within those 30 days to 6 months, Blue Door tries its best to provide many services, including housing retention, providing health supports and assistance, and also helping to secure trade careers so that they're able, the individuals experiencing homelessness are able to sustain or receive housing. They experience complex health and social needs, with a high percentage of their clients are managing mental health and addictions challenges. And some of the commonly noted reasons for ER visits or visits to the hospital include mental health or addictions challenges and crises, drug overdoses, medication adjustment. If there's no primary care available in the vicinity, then oftentimes clients will call 911 just to access primary care, such as for stomach aches, or for a warm bed and meal. There are some primary care supports available at Blue Door at Porter Place, but they occur once per week or once every 2 weeks. So if we go to the next slide, thank you, Leslie. So when we were conducting the interviews, we really wanted to understand what some of the pain points and key challenges were when patients were coming in and out of the hospital, and from the experience of both service providers, but as well as what they thought clients and patients were experiencing. And what was surprising is that although the sites are quite different, the clients are also very different. They're both vulnerable populations, very different. We expected that the challenges would be very different as well, but surprisingly, the similarities between the challenges were quite similar. And so we were able to summarize the top 3 challenges that stakeholders who we interviewed at both Keswick Gardens, Blue Door Shelter, as well as South Lake Hospital mentioned to us. So the biggest challenge experienced with respect to transitions is that there's an absence of formal information sharing process between providers when clients transition to and from the hospital. So because clients at Keswick Gardens and Blue Door are meant to be managing their health independently, often the staff who are at Keswick Gardens and Blue Door are not always aware when clients are calling 911 and visiting the hospital. And then when clients do visit the hospital, the only formal transfer of information that takes place from the community to the hospital is actually from the 911 paramedics. And so once the client arrives at the hospital and is admitted as a patient or is visiting the ER, hospital staff are also really trying to find out all of the information they can about the client and the patient. They're, consulting different, they're calling different providers, they're consulting different technology mediums to really understand what the health and social context of these patients are so that they can provide appropriate care. So as you can see, the information sharing is very consistent across different sites and different providers. Once care is being received and delivered, consent issues prevent information sharing between providers in the client circle of care. So Keswick Gardens and Blue Door may not always be aware of what's happening with the client, if they'll be back, when they'll be back. And the final thing is that primary care is largely only informed through the client. So if the client visits their primary care provider once a year, then the primary care provider will not be aware of when the client has been in and out of the hospital and for what reasons. So you can really see a disconnect with respect to information sharing, both as the client goes to the hospital and as the client is discharged from the hospital and back into the community. The second big challenge that was mentioned is that because, and I've alluded to this earlier as well, is that because the patients or clients are aging or they're vulnerable, they're not always able to self-manage and take care of their health. So if the hospital does provide a transition plan, such as booking of follow-up appointments or providing, changing their medication, they're not always able to understand because they may not have the health literacy to understand and follow up with all of the actions and care management plans that are required. And as a result, because of this, they may end up back in the hospital. And some of the providers at Keswick and Blue Door, so for example, PSWs, a lot of the things that might be required may be out of scope for a PSW, or the service providers are not always aware of what might be required because, again, of that consent and information sharing that may not happen. And the third is, this was expressed equally across the 3 different sites, is that there are concerns about discharges of clients and patients that may not be appropriate based on the type of care available. So a great example that was shared by hospital staff is that there might be a detox service that may be required by the client but not available. Unfortunately, the hospital is not able to admit client because of social reasons. So there's sometimes a disconnect between what might be required and what is available for the client. And I think it kind of alludes to a health and social care system that is increasingly serving very complex and vulnerable patients that it may have not been originally designed for. So if we go to the next slide, we summarize all of these challenges to our working group members, and the individuals that we interviewed were brilliant. I think they're all working very hard to create a lot of improvements, and they suggested a long list of 15 change and improvement opportunities, and we took a vote, and we landed on 2 big areas that we want to focus on right now initially for our initial tests of change. The first is formalizing a transfer of information post-discharge, example through transition plans for all clients. And the second is formalizing information sharing between providers, example through the use of technology. So something as simple as being able to communicate via email to check in on where clients are in the hospital, what type of care they're receiving, and when they're expected to come back, if they are expected to come back. So these will be the 2 big areas that we'll be focusing on. And I think we'll be covering next steps in the discussion, so I'll leave it there. Thank you.
Great, thanks so much, Simone. That was terrific. I just want to emphasize that what we've just heard is system inadequacies. Again, this is not about bad providers or bad delivery of service. It's about a system that was never designed to manage the types of needs that our populations have. And for those of you that looked at the list of the challenges that Suman outlined, you might say, well, that's a problem for everyone in our attributed population. And that may be true. Discharges from hospitals really are problematic across the province. But if you're homeless, or if you're marginalized, or you don't have anyone who's taking care of you, these system inadequacies are even worse for that population. Hence, the worse outcomes, the readmission, so on and so forth. So the client interviews were really an important way of garnering information that the OHT may not have understood beforehand, that were special challenges that this segment of the population was experiencing. So thank you, Simone. That was a wonderful way of gathering that data, and good luck on your journey going forward. Our next presenter, there's 2 presenters. There's Neil Shaw, who is the Executive Director at the Queen Square Family Health Team, and Salim Chattergoon, who is the Director of Integrated Health Services at William Osler. And they're going to talk to us about the work that the Brampton and Etobicoke, Ontario Health Team is doing. Take it away, you 2.
Great. Thanks so much, Mike. Pleasure to be here, and good day to everyone. I'm one of the many members of the Brampton Etobicoke Ontario Health Team, and I'm going to use this time to start off by just sharing with you the journey that our OHT has gone through in thinking about equity. And I want to sort of identify this as my version of this story, and there are many voices that probably contribute to how this journey has evolved. So our next slide, please. Just to situate where our OHT is located. sort of northwest of Toronto, if most people know in the province where that is. We've got just over 900,000 individuals as part of our population, 22 organizations and 108 clinician partners, mostly primary care providers, and 12 patient partners form the full partnership of what our OHT looks like. Next slide. So I want to sort of share, like, our approach to equity has not been a clear path. What I hope to do is sort of share the winding road that we've gone down. It's been a bit chaotic, and I think it's been influenced by external factors, many of which were identified at the beginning of this session. There are times where we've had to pause, stop, change lanes, and sometimes even just reconsider if we're moving forward in the right way. So really, all to say, it is a journey, and it's a collective one, and it's one where we are constantly evolving and developing. So when I think back to how our OHT came together in our first meetings, and this is still true today, I mean, they are, and they continue to be a place where health provider executives and leaders have come together to advance collaborative, integrated, and create an integrated health system. So at the heart of our OHT, and probably all of our OHTs, we have like committed, interested, and passionate healthcare leaders. People who are working in the neighborhoods of our community. And for us, that includes Brampton, Etobicoke, Malton, West Woodbridge. There are people who have a wide range of experiences, from the roles they currently hold to the roles they previously held, but also their own life experiences, from where they live, from where they work in this region, from conversations they've had with the people of their teams, their clients, their patients, their partners, their neighbors, essentially their own lived experiences, which they're bringing to the table. So the notion of addressing concepts of diversity are not necessarily distinct from what our everyday work is, because the makeup of our population is quite diverse, and these are the people we see every day. And so oftentimes we don't even realize we're taking that lens to the work we do, because that is who's in front of us, and that is who we are, and that is the work that we are doing. What I found is that the OHT has really encouraged a grassroots approach to how health leaders can connect and work together. And that's what we started doing. So we had large meetings where lots of people came together, and over time, as commitments were sort of required for timing, the group has gotten a bit tighter and smaller in terms of who commits and meets on a regular basis. And essentially, we formed an OHT collaboration council based on that. And it was through these meetings where these leaders came together that we started building trust amongst one another. And we started listening to what we were each doing in our various communities and who we were working with, understanding each other's experiences, and generally building trust amongst one another through that process. And I'll also add that our council includes 2 patient and family representatives and a number of primary care providers. And so all of these voices are part of that discussion. And so, because again, these are health leaders and people that are coming together, when societal events occur, it's the responsibility of leaders to act. And oftentimes we need each other to lean on for support. This was definitely evident during COVID. I think we all faced that. And I think for our OHT, coming together as a group, this was most evident for me in particular last year in May when George Floyd was murdered. And I think we grappled with how to address this blatant act of violence that was driven by racial hate. And I think our teams were hit hard. Leaders were hit hard. I was hit hard. We were all trying to figure out, what to do. So as a group of people who kind of regularly met, a few of us just reached out to one another to share, what were our practices on, how are we going to support our teams through this? How are we going to address anti-Black racism? So we just started talking about what we were thinking, what we needed to do, how we, needed to recognize this equity imbalance in our world, but then also the community in which we serve, the people who are part of our teams. And I think if I think back, I think it was, 3 of us that kind of got together, the next day that just started talking, and that over time, the group grew as sort of we started reaching out and talking to more people, to like 5 people, 8 people, 10 members, kind of all coming together to really share how we were going to address diversity and anti-racism. And essentially, we formed a collaborative of healthcare leaders who, had built trust through the OHT coming together, and we're coming together now to talk about anti-racism, diversity, equity, inclusion, anti-discrimination, all of these really key important issues. And because we were all members of the OHT, we also brought a summary of those discussions to our collaboration council so that it became evident that this was important. And over time, the group continued to meet over the months that sort of happened. Some people left, more people joined, and sometimes organizations started appointing people who were leading equity-based work as part of these discussions because they were the most interested. And so we started sharing resources and then our approaches to anti-racism. So in my opinion, like a very grassroots approach to discussing equity, but in a very structured environment. And so as our OHT matured, we started having conversations about structure and governance and priorities. And it was very evident that as part of our OHT, we needed to ensure we had equity as a focus. And we also needed to make sure, like, when you have something as a focus, there's a group of people dedicated to always be thinking about it. And so the collaborative that had been meeting since May of 2020 was essentially sort of morphed into what has now become one of our action committees, and it's the action committee focused on equity, diversity, and inclusion. And we formalized it. We got terms of reference. We added patient representatives. We've recently added a primary care physician. We've looked across sectors to make sure we've got good sectoral representation. So it's really that diverse group that we need it to be to ensure that this lens is taken. We've had our OHT has done strategic planning sessions, and it was evident and presented by the equity committee, but evident that all partners felt that diversity was a value that was importance, and was sort of stated as now stated as one of our values. The committee is currently working on a framework to determine how we formally embed equity into all of the work we do. And we're now working as well on establishing, a level of commitment across not just the OHT, but in every partner who's a member of the OHT to equity and diversity. And I say this because it's important, because the OHT is a network of healthcare leaders who represent organizations. And as such, all of them need to sort of subscribe and agree to, this being an important priority and bringing this lens to all of the work we do. All to say as well that societal impacts don't seem to be stopping with the, with the identification of graves of Indigenous children at residential schools, Muslims in our community being attacked, just for who they are. Our group, I think, takes the time to reflect on these. We pause, we ask questions, we reflect, and then we decide, are we still moving in the right direction? And we have to recalibrate based on this information. So I feel we're on a journey. The journey did not start, I think, with the OHT. The OHT has been allowed to bring people together to further it and I hope champion it. So that's our journey. And I'm going to share a couple of examples as well. But just before I do that, I'll share some data about our OHT. And I want to just point out one, if you just, when I speak about the diversity of our OHT, if we look at data from StatsCan, you can see the ethnic diversity that is represented in our community. And so, as leaders and organizations and providers, we are and we work with people who represent all of these ethnic origins. And the graph on the right sort of identifies the languages that are prominent across our 4 key neighborhoods as well. And then the next slide, I also want to just share a little bit of, oh, sorry, Leslie, can I get the next slide? Thank you. The diverse levels of income, when we really start looking at our neighborhoods. So the graph, the chart on the left sort of identifies the fact that we do have a number of the proportion of our population that is sort of low income is greater than what's seen in the province. But then more interestingly enough for us, when we're starting to plan within our OHT, as we look across various FSAs or the various postal codes across our neighborhoods, we see that there's diversity within our geography as well. And so we want to, pay attention to this. We have to make sure that, what a solution that works for one neighborhood may not work for another neighborhood as well. And just, I'll point this out because, data is always interesting. One of these charts represents individual income, and the second one on the right is household income. And we're very mindful of the fact that households in our geography vary, especially by the number of people that are part of households because of either multi-generational or multi-family homes in various parts of the region. And so that context is important in all of the planning that we do. So I'm going to next turn it over to Salim, who's going to share some examples through COVID.
Thanks very much, Neil. Sorry. Forgot I was on my phone. So what we wanted to do is speak to you about some of the ways that we've learned to take an equity approach in our planning as a result of the experiences we've had through COVID, mainly by sharing stories, because I think that's how we learned. And so like many OHTs, our OHT was involved in supporting Ontario Health with their testing mandate and public health with their vaccination mandate, as well as with the high priority community strategy. But I think one thing we've learned is that taking an equity approach to care delivery requires courage. I think that's sort of the key theme. So in the beginning, when we had the testing sites set up in our region, we had one major site in Brampton, one major site in Etobicoke, primarily operated by hospital and other OHT partners. Lots of OHT partners contributed staff to make those testing centers sustainable, but they were still kind of these high volume, high throughput sites. And in particular, North Etobicoke, Rexdale Community Health Center was doing a lot of work with the Health Commons Solutions Lab, speaking to the residents and the community members in North Etobicoke, and learned that a significant portion of them couldn't access the testing site, even though there was a large testing site right there. And things like not having a car, things being by appointment only and not accepting walk-ins, because that was the provincial mandate at one point, the inability to wait 3 to 8 hours in line in a car, hours of operation not working with the 2 jobs that they have and they couldn't actually attend, no supports if they did test positive, whether it's income supplements or childcare, general mistrust of institutions based on past experience. All of these things came up as issues for accessing care through these testing centers. And it led to many pop-up sites created within the areas that the communities would frequent themselves. And also even kind of these under the table conversations at the OHT level where it's like, okay, the province doesn't want us to do walk-ins, but that's not right for our community. So in the effort to be fair and try to make things better operationally, we have now created an equity issue. And what is our role as an OHT to try to rectify that? And so there is kind of this role, I think, that we've seen that OHTs need to sometimes enable people to go against the grain to do what's right locally, despite not always having the permission to do so, and which takes courage. And kind of continuing on that theme of courage, that the left side map that you see there around community testing, the very leftmost corner, you'll see a little blue dot there, and that's our Snellgrove area. Traditionally, that's been considered a health desert in Brampton. And there's a few other pockets as well, but that one in particular, the organization that Neil leads, the Queen Square Family Health Team, in partnership with Home and Community Care and other partners, what they did was established essentially a testing hub and a primary care hub in that region for testing and vaccinations. And what they had to do is secure the ability to use their resources as assets for the broader community, as opposed to saying, we're funded for our roster of patients, therefore we only see our patients. That's not the approach they took. And so the ability to kind of think as a system and then do what's required to get those processes and permission sometimes, or sometimes, apologizing before asking for permission, those are all things that were necessary, I think, to do what was right for the community. And the other blue dots that you see there are other community sites, mainly run by community support service agencies, who've identified those locations as key areas where access is a barrier or where there's community need. And when we were doing the planning for these sites, there was no guarantee that community support service agencies would be funded to do community testing at all. It was still very early days in the pandemic. But there was something about being stuck in a room of OHT partners for an hour and a half every single week through COVID, I think promoted the trust that it's the right thing to do. And even though things aren't funded, there's this faith that if we just kind of do the right thing, there'll be enough of us saying we need to figure out how to make this sustainable, that hopefully the sustainability and the funding would come. And so there's this kind of this dynamic, I guess, where trust breeds the support for courage, and then courage breeds equity, because you can actually do the right, implement the right services despite how you're currently organized or funding agreements that you currently have. And definitely the province and others did step up to provide that funding in time, but it was not something that was known ahead of time. And we also involved organizations like Punjabi Community Health Services or Indus Community Center and other faith groups in our planning, even though they weren't official CDMA signatories, because I think as an OHT, we felt that it was our responsibility to do what makes sense for our population and promote equity in our planning and really kind of get local intelligence to tell us what needs to be done, as opposed to adhering to self-made structural barriers, because it just didn't really make sense otherwise. So I think that was kind of a lesson for us, was just really just involving anyone who has a perspective on this and making sure those perspectives are elevated and then resources are put towards them. And then moving on to some sort of a vaccination story. In North Etobicoke, again, that on the right map, on the top left-hand corner, that's very red, that's North Etobicoke. So when the vaccine supply finally started to come in just a little bit, like it sort of, was dripping in, North Etobicoke was a vaccine desert for quite a while, for many, many different reasons. But another thing that at the OHT table we would talk about was Rexdale raising this as an issue, and that led to many different types of advocacy. So whether it was the hospital appealing to public health, both in Peel and in Toronto, to say, as an OHT, we care about both of these, but as public health, you have a specific boundary, and either way, this community needs care. What can we do about that? Whether it's advocating to the ministry and the province, there's articles in the Toronto Star, all just to kind of draw attention to this issue. And thankfully, Peel did agree to allocate some vaccine supply to North Etobicoke in an interim way. And then we were so grateful for the Toronto OHTs that stepped up to say, we'll do the vaccine administration for North Etobicoke, and they kind of worked with Toronto Public Health to get that going. And there were community-specific interventions like mobile pop-ups, again, homebound vaccinations, and lots of other conversations to organize vaccinations in temples, mosques, and gurdwaras, both in Peel as well as in North Etobicoke, to again take that equity approach and think about what the needs are of the community to actually help them get access to these services. So there was a bit of a role I think we've learned that OHTs have to advocate and sometimes magnify the messages that local intelligence already has, and either put the resources behind what they need or kind of get out of the way so they could do what they want, because they know what's right. And I think those are some of the lessons that we want to take with us into our priority population planning and the work that we're doing going forward. So we can move to the next slide, and I'll just briefly touch on how we're trying to apply this to our priority population. So pre-pandemic, we thought we really wanted to focus on diabetes, but post-pandemic, older adults experiencing frailty or the frail elderly population really stood out to us as a very vulnerable group that we're focusing on now. But what's interesting is the questions that we're asking. So we've noticed that many different postal codes that have had high prevalence of various types of health conditions, such as diabetes, are also the same postal codes that have had high prevalence of COVID. And it's making us wonder, what are the very local social determinants of health that are causing this phenomenon? And how do we actually understand that in a way that is more comprehensive than we do now? Because the data that we do have doesn't always measure things that we need to this in this local context. And then how can we actually work with these areas and these populations to design solutions that will make sense for them and actually be helpful, and really leverage local intelligence to do that, and partner with people who know these local areas to be able to guide what we actually do. And just like how testing and vaccinations essentially required us to segment the population for people who have a car and can attend a large site versus people who couldn't, we know that a senior that's part of a multi-generational household in Brampton has very different needs than a senior who's maybe living alone in North Etobicoke. And what we want to try to do is really tease out what are those unique needs, barriers, and risks for those populations, and then design integrated care models around each of those. I would say that we feel like we've barely scratched the surface on this work, but in some ways we're really grateful to the experiences we've had during COVID, because we've been able to start asking these questions early on in the journey, and hopefully we'll just get better and better at it as we learn collectively from other OHTs and our own experiences as well. So with that, I'll hand it over to Neil for just some other key learnings and to close.
Thanks, Liam. It's interesting to always step back and hear you talk about our work over the last year, because I feel like we've been so deep in it. It's nice to sometimes step back and just hear how it's all flowed. I think, what we've learned over the last, year or so, and they're summarized here, but one is, because we do represent such a large and diverse geography, that planning has to be driven locally, and locally can mean at the neighborhood level as well. Because there's diversity within those neighborhoods, and we're really starting to unpack what that looks like. And sometimes when we look at data and information from a larger regional perspective, we may miss some of those very specific things happening in very local communities. Which leads us to sort of the next part, which is, so then you go to those communities and you find out, who's working in that area. And I think, like previously said at the opening of this session as well, you find out who's working in there, you do that asset mapping, and you ask them how to help and how to move forward. And then as Salim says, you get out of their way. Like you basically wrap the supports and programs around them. And we did that with testing. We knew like provincially and regionally how to implement testing, and we basically went to the neighborhoods where we knew it was a challenge, and we just went to them and said, okay, here's all the resources we have regionally. You tell us how to deploy them in your neighborhood to make them work. And I think that's when we started to have success, is when we took the courage to basically try things differently that would work very specifically for the neighborhoods that we were working in. I think I'm gonna close there. Salim, I don't know if you have anything else you want to add.
No, keep forgetting I'm on the phone. That's everything. I think we have a couple of extra slides in the Q&A. We need to address them, but I think you've covered it, Neil.
Wonderful. Thank you so much, you two. I think if there's anything good that came out of COVID, it was the way we've learned about how our communities are set up and how they end up being marginalized over time or racialized. The learnings by postal code are extremely important. And again, Health Commons Solution Lab can help you thinking about postal codes and where do people live and how are they living. I think what really struck me about this particular work is the understanding the culture that we're currently living in, the world that George Floyd's death has created, the residential school, finding the unmarked graves of children that were murdered. We're now in an environment where this work is even more critical. And what I like about the way Brampton and Etobicoke went about doing this is they recognize this is the environment we're working in. So we can't just be very technical about our equity work and say X number of people live here, X number of people live there. We have to understand the culture around what's going on in our society. So I really appreciate that lens, especially Neil, when you talked about your journey. And if I can editorialize for 1 second, what the Brampton Etobicoke experience also uncovered was how racism in the media, what we typically see are people screaming racial epithets in people's faces. So that's what makes the media. There's a more subtle bias in the media that marginalizes groups like Brampton Etobicoke by not talking about the history and the background of how the communities came together. And so by leaving it sort of blank, what the media did with Brampton was sort of brand this area as a bunch of those people that don't know how to live properly, and look, they're spreading COVID. And there was this undertone racial message. People may disagree with me, but what was great is you managed to look beyond that and pull out the story about what's really going on. So again, I think when all of you are looking at how you apply your equity lens, take a look at what's going on actually in your community. What are the kind of messages that are being given either by local media or city councils or whatever about marginalized population? Are those messages systemically racist? Are they systemically biased against people that are in lower SES communities? And are they blaming those people for the situations that they have to deal with? Because I think that's a very important part of understanding how to apply your equity lens. I'll stop editorializing at this point, and what I'd like to do is do a quick poll with all of you around the supports that you need around applying your equity lens. And so Steve, if we could go to the poll, great, thank you. Check all that apply here. So what we want to know is what support do you need to help apply an equity lens to the transformation work that you're doing? So check any and all of the boxes. If you check other, please enter what the other is in the chat box so we can better understand what other support you might need. So we'll give you a few seconds to fill that out, and then I'll prompt Steve to give us some results. There'll be a bit of a lag, but so don't worry.
I can see them all coming through, Mike, as Steve puts the poll up. So about 35% of people have voted. And right now, the one that's starting the pop is using data to understand inequities in care. So votes are still coming in, but that seems to be the one that's pulling ahead of some of the other choices there.
And for any of you survey researchers, you would be horrified that we talked about the results before the poll was finished. So just teasing you, Leslie.
I'm used to it.
Okay, great. So as Leslie said, the majority of you are trying to understand how to use your data to understand inequities. I think both these presentations gave you ideas of how to do that. There's COVID data that's available. The client interviews that Southlake did were fascinating. There's a variety of ways of doing this, and Cynthia and Zawar can also help with what other kinds of data can you find. Developing an equity framework, I think that's important for one of the things, I'm going to editorialize again, and I'm sorry. One of the things that's really important in our work is the ability to share across OHTs. So I know that some OHTs currently have an equity framework, and it may not be finished, or it is finished, but we need to start sharing that stuff with all the other OHTs so that not everyone's in reinventing the wheel. So we as coaches are really going to be pushing our teams to share what we think are great ideas, great products, so that other teams can pick them up and start using them or adapting them to their local environment. So for those of you that have an equity framework out there, please share it with your coaches. We'd like to put it up on the online forum so that others can learn from what you've done. Another big area seems to be how to select and implement interventions and strategies to address inequities. So again, go to your coaches and they will try and find you the ways to do that, but also share if you've developed a particular intervention to address particular inequities, please share that. Either share it now, share it online, or share it with your coach. So with that, I'm going to close the poll right now, and we're going to go to a Q&A. What I'd like folks to do is, if you have questions, come off mute and please ask your question. It's fine to put them in the chat too, but we'd much rather have a conversation. So I'll start off by saying that I'm just looking at the chat here. Michelle James has said, I think it's important to consider both quantitative and qualitative data, including stories and feedback that elevates, chat there for a second, that elevates the voices of equity-seeking groups. I couldn't agree more, Michelle. Do you want to say a bit more about that? Is that something you've been working on? Hate to put you on the spot, Michelle, but it's such a great point. Are you there?
Oh, sure, no problem. Thank you. Answering the poll. My interpretation of data was both quantitative and qualitative, because I think the two together really add a richness, especially since we don't have sufficient quantitative data at this point. And I think a good example is the experience with vaccine clinics, where the collection of sociodemographic data is not where we need it to be. So in our community, we also did some focus groups with various ethnocultural, religious, racial groups. And then just observation. I try to get to the clinics and see, who's there and who's not there. And so just putting all of that data together, I think allows us to make better decisions.
And Michelle, when you're collecting those socio-demographic data, do people have trouble getting that data? Or do people have trouble answering those questions, in that they feel it's I think it's a myth. The myth out there is that it's a violation of privacy.
Yeah, we haven't had that concern. I think we've had people hand in their forms. One day I was at a clinic just at the exit taking those forms, and there were some that I got back that were blank, and then there were some that were filled in. And I think maybe the onus is on us to provide more clarity and an explanation. That was lacking in our process. But what we've heard from other clinics is that, or from the province, is that the resistance is more on the part of those collecting the data who feel a little uncomfortable asking those questions. Some of the questions are sensitive. So the data that I had heard was that of the folks that do get invited to complete the survey, about 97 or 98% actually do fill out the form, but we're actually not giving the survey to very many people. So I think there's a training opportunity there in terms of collection of the data.
Terrific. Is the tool that you're using something you can share?
Yes, it's the one that we got from the ministry.
Oh, okay.
Yeah, the sociodemographic data collection tool for the clinics.
Okay.
Yeah, sure.
I'll track that down and put it up in the online forum. Thank you.
Yeah, okay. Yeah, if you don't have it, I could send it to you.
Okay, that'd be great too, in case I can't find it.
Thank you.
Okay, Salwar's put up some information there around tools that can be used, increasing data uptake for sociodemographic data. Andrea and Matt both identified the need for resources, as they clicked other in the poll and said need for resources. Can either one or both of you talk more about what you mean when you say need for resources?
Andrew, you want to go first, or I can jump in?
Jump in, Matt.
Thanks, Mike. This is something that we've been really focused on, obviously, and it's so important. And we've heard as well, as some of the people have suggested, the importance of qualitative research, right? We keep talking about that, which is really important to get that more contextual information. It requires people and time, and that costs money. So, I think it's groups like this that really can work together to look at how can we share resources where there's opportunity to do that, especially within adjacent OHTs. I hope we can form some of those partnerships. I think sharing what we find across regions and things that are generalizable is really important. And then the other thing that we have the benefit of in our OHT, so I'm from London with the Western OHT, but we have academic partners in our region because obviously Western is here and not all OHTs have that resource. So we've been partnering with people at Western to see how we can leverage some expertise there, and then certainly, offering that wherever possible to surrounding OHTs and seeing where we can partner and work with other OHTs as well. So those are some of the practical things we're looking at, but just, I think everyone would agree that, this is so important. But it requires a significant amount of resource just to make sure that we're getting it right.
Couldn't agree more. And time is also a real resource too. When I talk with many of the OHT leads, they want to share, they say, oh, we're just so swamped. So again, if sharing information is time intensive for you, again, use your coaches to share that information. Give them the information and they can help you get it shared across the OHTs, or get your questions answered around who to talk to share information. Andrew, did you want to add anything to that?
No, I echo exactly what Matt said. Like it's, I think many of us have a good sense of what to do. It's just balancing the competing priorities and taking the time to guide the rest of our program services, data quality leads in that application of the lens. We're, in Muskoka, we're still in the early stages of increasing the functionality and the high performance sort of targets that we want to achieve in seeing the patient flow and quality metrics, and then to sort of apply that equity lens on top of that is a lot of work that falls upon sort of the leads of all of these committees. So it's great to take part in these sessions and hear others' perspectives. I just sent Neil a note previously and comparing sort of his maps, and it's also important to note we don't need perfect data to drive sort of our work forward. Sort of as long as it's quality data, sort of garbage in, garbage out kind of thing. We still need sort of to realize it doesn't need to be perfect for us to make our best steps forward in advancing the equity perspective to the populations and the attributed populations and the patients that we serve.
Yeah, it's a great point you're making, Andrea, and I can't emphasize it enough. Good enough data is good enough. Remember, we're not doing research projects here. We're not doing accountability or evaluation data when we're trying to get a handle on what our populations look like across our geography. So good enough data is just fine. I noticed in the post, Karen Milligan, you're here, which is terrific. She says 211 collects socioeconomic data about those who contact us, as well as what their needs are and any unmet needs, service gaps, and the barriers to access. It's available through a public dashboard, but can also be shared with OHTs for individual catchment areas. When we talked with Karen, Leslie and I talked with her and her team a while ago, this is a gold mine. Karen, do you want to talk a bit more about how the OHTs can make use and access these data?
For sure. And again, I like your point that you made, Mike, about, it doesn't require perfect data. Sometimes it just requires information that is aggregated. So I'll talk, and when the group was talking about sort of doing that asset mapping and identifying in particular barriers to service, that's where it sort of occurred to me that this is really relevant to this group, because we do track when people contact 211, we track what their needs are, track a little bit of socioeconomic data. We are starting to collect more race-based data, but it's very much in a pilot phase right now. So, I won't say that we have a lot of data in that realm yet, but in terms of being able to understand what are the current barriers to service, if we'll collect information when we track an unmet need. So if somebody contacts us about accessing a service, and mostly in the social services realm is where we're focused. So of course, it could be a food bank, it could be a mental health program, or it could be a social program for seniors. If we track that there's an unmet need, that could mean a variety of different things. It could mean they don't have transportation, could mean they can't afford the program, it could mean the program doesn't exist. So there's a number of reasons, and I equate all of those to barriers to access, because it's not always just that there isn't a program that exists to connect people to. So all to say, that information we collect, there's about 350,000 contacts last year to 211 across the province. So clearly, you know, the volume is heavier in some communities. So it's not, you know, in some smaller communities, there may not be the volume to make it relevant, but it could flag an issue that would require further investigation. So all to say, it's there. We are sharing it already with some of the OHTs that we're working with locally, but that information is also available through our website, publicly updated every 24 hours. And you can hone in on particular cities or communities if you want to see needs specific to those communities.
So this is an incredible wealth of data. As I said, I was blown away when I talked with Karen. Karen, can you do me a favor? Could you put your website URL up there and maybe the URL that gets you right to the dashboard so folks can take a quick look? I would urge you to contact Karen. Sorry, you're going to get lots of emails, but for those of you that have no data or don't even know where to start, this is a fantastic database that can help you start thinking about it.
And sorry, Mike, one last thing I'll mention. This isn't, you won't get this through the dashboard, but we also do have an extensive directory of all of the health, social, government, community-based services, right? That resource directory. So for asset mapping, I know some of the OHTs have already used that data, but we can connect people to that through APIs or Excel spreadsheets, depending on the catchment area. So I'll definitely include the link. Let me grab it.
Fantastic. Thank you so much. Zawar, I noticed did you want to give us some advice, pointers, whatever?
Yeah, I mean, I've just been reading the various messages in the chat and listening to the conversation. I agree. I think, you know, the equity work has to be done properly, and to do that does take time. But you know, you can start modestly. It doesn't have to be a big bang up front. Start modestly. Think about what you have at the moment. Think about where your gaps are in terms of identifying your partners, what data you've got, and what data you can collect. I think. In some of the resources that we've shared in the deck that Mike spoke to today, I will give you examples of how you can, for example, undertake asset mapping in a modest way, bringing together partners and using the clients and community members and providers to help you to do the equity work, bringing in that kind of expertise. The other point that I just want to make is if you're not thinking about equity issues when you're planning and designing your services, then you potentially may be making some savings in time and resources up front, but you might find that in the longer term, you end up using more resources to try and address the issues and inequities that some of those populations are experiencing. And so, you know, it could be a false economy. And I'd look at it more as a kind of investor-save approach, putting the time in up front, actually to design better services, particularly for those communities that have potentially poorer access, poor experience, and poorer outcomes. And if you're getting it right for them, then you're getting it right for the rest of your population.
Wonderful. Thank you. So we have lots of resources here. We have the Health Commons Solution folks. We have Ontario Health. Cynthia has put up a link to some data that you can get. We have the 211 folks. I think, you know, part of this journey that, as Neil and Celine pointed out, it doesn't have to be perfect to begin with. You just need to start it. So don't wait for perfect data. Don't wait for all of the possible data that you might need. Take whatever data you have and see where it takes you on that journey, because it will highlight for you within your particular OHTs where you might want to start focusing some of your effort, even if you're not addressing everything all at once. Don't try to do Lori, you've got your hand up.
Yeah, I just wanted to, ask Neil if he would speak a little bit about comment that was in the chat earlier about making sure that representation on their equity committee, was very broad. But when I think about how their committee started, in result of from 3 people chatting about something that was, affecting them individually as individuals in their teams and people in the community. But they started as a group of 3. But then there was suggestions in the chat that, they needed to look to make sure all the voices were included in their committee and stuff. So that's a bit of a transition. And when do you make that transition? And, that committee is now formalized in their structure. I don't know, Salim, if you want to put up your org chart, but so people can see how that's been formalized within the structure. But how do you make that transition from a small group of highly motivated people that can accomplish a ton of stuff to being more formalized, having all the voices at the table, but not letting that slow you down? So, Neil, I just love to hear your perspective on your evolution to formalization without losing the passion that drove that initial work.
Thanks, Lori. And I think, as you've described it, it was very organic in that sense of it was, a few people recognizing this was, coming together to talk about it. But then as we talked to more people, what we learned in our community was there was lots of people passionate and wanted to be part of this work, which is what kind of had the committee, had this group of people grow. I think the formality of it and like the actual structuring of the committee came as the OHT itself evolved, because we've all been on this journey where, we started with, again, just groups of leaders coming together to all of a sudden now we have collaboration councils and committees and primary care networks, and like all of this is forming over time. And so as a collaboration council got formed, it was like, great, we now have this council. And it's like, well, we need a PFAC and we need like an MAC. And it's like, well, we should have an equity committee. It's like, okay, well, these are things that were important to what the OHT identified, keeping in mind that the same people that were getting together were also part of all these other committees. So they could recognize where quickly these informal grassroots groups could fit in very nicely into a formalized structure. And then to the comments, I think once you start moving to that more formalized structure and you create things like, what's your roadmap of activities and you become a committee, you start thinking about membership and you think about governance and like all of those elements. And so what started as a group of leaders who then said, well, it's maybe not the leaders who should be here, but also the experts who are the subject matter experts in our community who need to be part of this work. So part of what we did as a group was every now and then we just look at our membership and say, do we have all the right people here? Are there others we know who we should invite, or are there other voices that are missing from this table, and should we reach out to them? And so I will say we've done both, and sometimes when we've reached out and just put a call out, we kind of get who we need, because I think people also self-identify, because we present at a partners meeting, for instance, about the work we're doing, and all of a sudden we have a sector who doesn't see themselves represented in the committee say, I'd love to be a part of this work. And of course we're like, great, thank you. Because we can't sometimes, we don't sometimes think about all those areas. And there's also been a few groups that we wanted to engage in this group who aren't part of our OHT. And we said, would you come join our work? And, I'm going to be completely transparent. They politely declined at this time. They said at this time, they did not want to be part of a formal OHT structure. But of course, they said, if we can help with anything, just give me a call, right? So it was one of those, they didn't want to be part of anything that had to do with a formal OHT today, but they knew this work was important. And so, I think that's important to recognize, as well as where people are at and how best to work with them too. And I think, like for instance, if we were doing work in our first priority population, for instance, seniors, we know we're going to have to call this group and ask them, like, how do you address it for the specific group that you work with? Because they're, an important element to the population that we serve. And we know when we put up our population data and we do a segmentation by a certain type of geography and a certain ethnic group, they're going to be the group we have to talk to. And so it becomes very, we know who we have to chat with on that front. So I think sometimes being formal can also be a hindrance. And I think that's important to understand as well. So having some level of being a little more open and allowing people to flow in and out of structures may help bring in people who have traditionally felt not represented in a group. And our goal is to try to bring more people into the fold as well. I just want to, I was reading the comments and I guess the way I was trying to figure out how to write this, but essentially our collaboration council did a really good job around identifying all the different neighborhood sectors, groups, like et cetera, that needed to be part of a leadership group. And our equity committee is a bit of a mirror of that. Diverse sort of representation of all the different groups. It's not 100%, but it's a fairly good mirror, and it allows us to sort of compare sometimes to say, oh, in our collaboration council, we have all of these areas represented. On our committees, how are we mirroring that level?
Yeah, and I think just even working with your team a little bit, I think as other teams may look at building equity committees, I think your message of knowing who you need to connect with is more important than your membership list. I mean, your membership list is there and you check in with it all the time, but I think just knowing your community, knowing who your people are, I've heard you guys talk about reaching out to people depending on what the question is. So I think that's a really important message for people to hear as they, even maybe the cohort 2 teams who are a little bit further behind in terms of building their representation versus building their voices and their representation versus building their committees. So just glad. Thanks so much for sharing that.
Thanks, Laura.
Salim, I see your hands up.
Yeah, I just wanted to build off what Neil was saying too. And I think like when I said that we kind of have an org chart, I think it makes it sound more, it's not magical. Like it's not, it actually probably detracts from the work that actually gets done, because it's basically all of the groups that we have that feed into the Collaboration Council or advise the Collaboration Council, and the Equity, Diversity and Inclusion Action Committee is one of those. But it kind of makes it look like it's just one way. And really, I think the work of that committee has been to be voices at the table for any work that the OHT has done. So the visioning sessions, the values, mission, all of that strategic planning work that we've been doing since January, they were one of the committees that were consulted, and they attend our partner meetings as well. And a lot of the value statements reflect the equity principles that we want to adhere to, and they'll be codified in the next update of our CDMA. But at the same time, the way that we do engagement in the OHT, if we have kind of a broad issue that we need to take to the partnership, it usually goes to the partners, and then it goes to the equity committee, patient advisory council, and then the community MEC to kind of further flesh out specifically what are the equity considerations we're not seeing, who's not at the table, what is the patient and kind of caregiver experience that we're not seeing, and what do we need to do? And then from primary care's perspective, what are we not seeing? And then it kind of goes to the Collaboration Council with sort of final recommendations and approval. So I think it's more, it's about how we work whenever issues come up, and when we need to kind of tackle decisions as an OHT. It's that it's always asking those questions about equity first, and making sure that those get reflected in any recommendations we make going forward, which I think is what the journey has been this past year, ever since we've kind of become more formal. And the second piece too is a lot of people have been mentioning too, just the resource and the time needed to think about these issues is something we don't have, right? Like it's sort of this, COVID is still, like it's getting a little bit better, which is great. Let's hope it continues. There's a lot of OHT development work, and then we don't really know if there's this looming timeline that the ministry is going to drop on us to say, like, show us results by when we know that this really needs dedicated time that really isn't dictated by the way we would normally do things. Part of what this committee recognized was they do need that resource to kind of take the work in between meetings to drive the development of the framework. And Neil was, I would say, very instrumental in kind of contemplating that role. And Aju, who I believe is on the call, he's like day 4. He just started as our equity, diversity, and inclusion lead that will support a lot of this work, help to develop a framework and kind of really help all the values that we're trying to establish in the OHT live in the way we do things. I think that's the one thing that was really important for this group, is not just to say we value equity, but actually show it in the way that our discussions show up, and not at the very last, the tail end of the discussions, but at the very beginning. So we're kind of looking forward to getting a lot of the meat of this work off the ground by having a dedicated resource to it.
Thanks, Salim. Zawar, I'm going to give you the last word, but before I do, I just want to tell folks we're at time. There's a question from Ruth Hall around whether you find your indicator reports useful in your equity work. So please type into the chat in answer to her question, and make sure you look at the last few slides about upcoming events. And Zawar, go ahead.
Thanks, Mike. And just very quickly, I think these are all key points that Salim and Neil making and Laurie's question. And for me, I think it is this kind of moving from theory and discussion into practice. And so what are we doing in the committee there that we're then turning into actual, I describe it as action on the ground, and how we're making a difference for the populations that we're thinking about. But we keep that in mind, really. What difference are we making, and where are we investing our time and effort?
Well said. Wonderful. Thank you so much, everyone, for joining us. Sorry we ran over time. These discussions always do. Again, if you have questions, reach out to Leslie, reach out to your coach, and let's make sure we connect all of you together and are sharing resources. And have a wonderful rest of your day. Take care.
Everyone.
And thank you to our speakers. Sorry about that.